That other one, infective endocarditis as well. So that can be some big things. Remember, your symptom presentation is going to be what valve that is going to be affected. So as I'm doing my assessment and I see certain things and not other things, then I can narrow it down even further. So if I start to see pitting edema, if I start to see JVD, I know that I have that right-sided heart failure. So either I have some type of mitral stenosis that's kind of early, or maybe I have aortic issues that is a late sign, because that late sign of right-sided heart failure is going to be big on those valves. Lung sounds, that's kind of easy to assess, right? So if I have that pulmonary congestion, I can easily single that out. Are they in AFib? AFib can be a big player. The valves, as they are starting to become less and less compliant, whether they're opening or closing, it can cause AFib to occur. So let's think about AFib in general, not even worried about the valves at this point. Overall, AFib is going to increase or decrease my cardiac output?
Decrease.
It's going to decrease my cardiac output, right? It's not beating efficiently. Those atriums are not beating efficiently, allowing for that circulation of blood to occur, not getting that good cardiac output as I should. So with AFib on top of those valve disorders, again, my blood is not circulating as it should with those valve disorders, decreasing my cardiac output. So if I have AFib and valvular disorders, that's a double whammy. Two things against me that's going to hurt my cardiac output. So I need to know what type of rhythm are they in. I can also get a chest x-ray, so I call Zach, he gets a chest x-ray, and he's going to tell me that the patient has mitral stenosis based off the chest x-ray. Well, how is he going to know that?
He's going to measure the heart.
So remember, that mitral stenosis, that mitral valve is not opening up as it should, causing that backflow of blood into that left atrium. So on that chest x-ray, we can actually see, it's very hard to tell and hard to look at, but you'll also be able to see it on an echocardiogram or something like a TEE, but we're gonna see that left atrial enlargement because of that backflow, that increased volume in that left atrium. We're gonna see more prominent pulmonary arteries because of that backflow. We're gonna see the signs and symptoms of that valvular disorder in the chest x-ray, how it affects our heart. You're gonna see that dilation. You're gonna see that hypertrophy occur on that chest x-ray. Even better things are gonna be that non-invasive echo, a TEE, so transesophageal echocardiogram. And then you get a transthoracic echocardiogram as well. And then cardiac catheterization. That's gonna be the big one. Non-surgical wise, non-surgical is gonna be big on your medications. What type of medications I can give to help my heart beat as efficiently and preserve as much heart function as possible. That is my goal with medications. So those things like diuretics. Why diuretics?
Keep the fluid off.
Keep the fluid off, right? A lot of my problems exist because of the fluid volume overload, because there's too much fluid circulating or backflowing one way or the other. So if I give them a little bit of diuretic, I can pull off some of that excess volume. Or maybe they already have some of that right-sided heart failure, and I can get some of that pitting edema off of them. Maybe a beta blocker. I can slow my heart rate down enough, preserve some heart function because my heart's not beating so fast, not working so hard, so I can help my heart rate out like that. Help my heart. ACE inhibitors, I can help my blood pressure. I can give something like a digoxin or a calcium channel blocker. Those are going to be big in what?
Okay.
AFib, right? Remember that AFib. AFib is going to decrease my cardiac output. Same with my valvular disorders. kind of a double whammy there. Your nitros are gonna help relieve some of that stress on that heart and dilate out some of those, and help kind of with that chest pain and stuff. With that, we're gonna be using it a little bit cautiously with that aortic stenosis. With that decreased cardiac output, it's overall gonna decrease our blood pressure. I don't wanna vasodilate anything out even further. Potentially have some type of syncopal episode because of a sudden drop in my blood pressure. Past the drug therapy options or medications that we can give, we have a couple of non-invasive type procedures that we can do. First one's called a balloon valvuloplasty. These are going to be big with your stenosis type disease processes, for your stenosis. With this, we're taking a sheath, a balloon, putting it up through that femoral artery, floating it through until we get into that mitral valve there, and then we're going to open it up. We're blowing that balloon up, trying to unstiffen, if you will, that valve. Very temporary type of solution. This is not really a permanent fix. This could last months, it could last weeks, really depending on the patient. But we're gonna need some more intervention at some point with this. Immediate goals is to preserve that heart function until we can get to that new point. I gotta get my heart a little bit better so it can tolerate these other procedures and preserve that heart function. A big one that we're starting to do is what's called a TAVR, transcatheter aortic valve replacement. So that's gonna be the second bullet right here. With that, we are putting a replacement valve on the end of that balloon and actually placing it as we are blowing that balloon up and allowing it to stay in place. So it kind of folds these valves up and out of the way, creating new valves for us where we need them to be. East Alabama started doing this pretty often. With that though, you need to have a cardiac surgeon on board. We won't go into detail about that at East Alabama, but with that, we have hardware inside our heart. So we gotta be on some type of antiplatelet therapy and a daily aspirin. I don't want clots forming on that new hardware. When that blood passes by, it sees something foreign and it wants to attack it, it wants to attach to it, it wants to clot to it. So we're gonna have those clots start to develop. So I have to decrease that clotting factor so I don't develop those clots. You can also do something very similar with the mitral valve repair. And then you have mitral clips too that kind of help open up that mitral valve as it opens. Surgical side. Only thing that can really fix the aortic stenosis is gonna be a surgical treatment option. With the others, you can do some of the others, but the main big thing is gonna be a valve replacement. You gotta replace that valve. Two different kinds. We have the reparative procedures, and then we have just the valve replacement itself. With the reparative procedures, we're going in and we're actually kind of reshaping or redesigning, however you want to say it, the valves itself. Either we're trimming off some of the excess or maybe like a prolapse, or maybe getting off some of that excess calcification, those chordae tendineae that are stiffened, that are tight, we're allowing those to open up a little better. Sometimes we will also, this annulus right here, so it's like a stiff outer ring that your valve leaflet's attached to itself within your heart. We'll actually repair that as well, and that can cause some of that stenosis, that stiffening to occur. And so once we repair that, we can actually allow for better flow or better movement of those valves, okay? Other types are gonna be that complete replacement, like I said, that heart valve replacement. Two options. You got your prosthetics, your synthetic kinds, your man-made kinds. Then you have your biologics or your tissue type valves. With your biologic type valves, you have your porcine valves or your pig valves. I can get it from the heart of a pig and put it in there. You have our bovine options, so a cattle or a cow valve. I can also cut it out of a human cadaver and put it in you as well. So there's a couple options. The downfalls of your biologic valves, and it may not necessarily be a downfall, but one of the things about a biologic valve, that it only lasts for 7 to 10 years max. After that, it wears out, and you have to go back in and put another one in. Prosthetic valves, that's synthetic valves. Little piece of metal in there, hard plastic, something along those lines. It stays in you forever. You don't have to get it replaced. All right. You got to be on lifelong. Usually, it's going to be warfarin or Coumadin therapy, antiplatelet therapy, with your synthetic valves, because it is some type of extra hardware, something your body doesn't recognize, and it wants to attack it. With your biologics, you don't have to be on any type of anticoagulant therapy. You might be on like a daily aspirin or something like that, but you're not required to be on something daily, because it's actual tissue, soft tissue, skin tissue, valvular type tissue, and so the blood doesn't clot to that. So there's pros and cons to both. So why would somebody, let's think about it, choose a biologic or a tissue valve over a synthetic valve?
If they already had clotting problems.
Maybe if they already had clotting problems, good. So maybe they have had recent history of a bleed. Maybe they've had a hemorrhagic stroke. Can they be on Coumadin therapy if they've had a recent hemorrhagic stroke? No, it's okay, so that's gonna be a big consideration. Things we're gonna think about when we talk about that past medical history. What if they have frequent GI bleeds? No, probably can't have Coumadin therapy, right? So that could be an option. Other thoughts for a biologic valve. Remember, it's only 7 to 10 years. Who would that be a good candidate for?
A 90-year-old woman.
Why?
Because she's probably not gonna live more than 7 to 10
She's probably not gonna live 7 to 10 years, right? Okay, so what's the point of putting a synthetic valve in that's going to last forever and having to do warfarin therapy, having those frequent blood checks, having to go into the office to get that titrated, to take more or less, and she doesn't have to memorize when she needs to take it, has to figure out, I gotta go back to the doctor's office. If she's 90 years old, let's put a biologic in her, let her go on about her day, she's probably not gonna live 10 years, right?
Do they take any immunosuppressants or anything?
They shouldn't.
Okay.
Sam?
Okay, so let's just say for whatever reason, a younger person can't get synthetic or biological. Is there like a maximum times it can change, or?
So good question, we were fixing to talk about it, that was my other option. So, young kids, that might be a good option, right? What do kids do? Fall, well, they do fall. They grow, right? So, as they grow, is their heart gonna grow? Yeah, and so are they gonna need a different size valve?
Yes.
Yes. So about every 10 years, 7 to 10 years, they'll go back in for another procedure and get another one until they get about the size that they're gonna be. And then they might have the option for a synthetic valve. But if they're in their 20s or early 30s, do they want a synthetic valve? Do they wanna be on that lifelong therapy? That's kind of a personal decision. But it's a good option because they are growing so frequently. They're going through so many changes that it's gonna be kind of a temporary thing until we get to a more stable size, if you will. Okay. Natalie.
I was gonna ask you if they changed them for kids because of the growth.
Yep.
So you answered it.
Drew.
So they take it from cadaver, dead tissue doesn't interfere with living tissue?
They gotta take it quickly,
Okay.
so, I don't wanna go there.
So is it like a waitlist for this?
I'm sure there is, for the biologics, but I'm sure there's lots of pigs and cows around.
Like, I'm like, I guess you could just go and
I mean, I don't think they were like, all right, that's my cow I'm using, and they slaughter that one, like, that's the valve, that's mine.
You never know what folks
I would be
I mean, we are in Alabama, so there are stranger things that have occurred. I've slaughtered a cow and processed it myself, but I never thought about taking the valve out if I needed it for later, but,
Sit up.
I would just not be comfortable with a pig valve being in my heart. I would just like,
as long as you don't start oinking, I guess you're okay. What you got?
I'm not gonna
I would
say it.
think that, there'd be a higher chance at, rejection with biological. Is there a difference with like rejection? Cause I know it happens with all kinds of like organ donations with like humans. Is there a difference with like cows and pigs?
I don't know, honestly, I don't. That would be a good research article for you to find. You will not be tested on that, I know that, so, a good research article for you to figure out. And then on the other end, we have the prosthetic valve, the synthetic valve. Is my patient able to be compliant on their medication? They have to take the Coumadin every single day or as directed, because sometimes you have to take it every other day, that kind of stuff. But are they able to cooperate with their primary care provider or their heart surgeon to take their medication as they're needed? If they're not able to, then maybe they're not a good candidate for this. Or are they okay with taking it continuously? Some people don't like taking medications. And so they're kind of scared about taking a lifelong medication. Or the frequent blood draws that's gonna happen with it. We've got to check their INR pretty frequently. Are they compliant enough to go to their primary care provider maybe once a week or twice a week even until we get a real stable INR, especially in the beginning stages, to check that INR. So I know if I need to take more medication or take less medication with that. So a bunch of different things that we gotta think about when we're recommending or thinking about what type of heart valve that can happen. So here's a couple options right here. So A and B right here are your two pig valves and two pig valves, and then your synthetics down here at the bottom. Your A is a little bit different than your B. A does not have that stiff annulus ring around it. It doesn't have that framework structure. And then your B has this kind of structured ring around it, very similar to our heart valve itself. And then you just have that synthetic down there at the bottom, okay? Synthetic valves are real cool. Zach.
I was gonna ask about the synthetic. Can't some of them make a really loud clicking sound that can drive people crazy?
Yes, I was just fixing to say that.
Oh,
actually.
okay.
So,
Sorry.
so I'm talking about mother-in-law and my father-in-law again. Mother-in-law has out of valve replacement. She had a synthetic placed. Father-in-law had a synthetic valve placed as well. He didn't get an option because his aorta dissected, so it bursted. But so emergently in surgery, they're like, you're getting a synthetic valve. But when me and him hunt, and it's completely quiet out there because we're being quiet, and he usually never sees any deer because his eyes are closed, because he sleeps in the deer stand. His mouth opens, and so when you're sitting there, and as I'm watching whatever goes by, because one of us has to have our eyes open, or we're not gonna see anything, As he has his mouth open, you can actually hear that audible click every time. So you'll be in the middle of the woods and you just hear this click, 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 click. And then sometimes you'll hear a click, click, and then it just click, click. And so you can actually hear it. Really, really cool. And then same with my mother-in-law. She has one as well. She's never really quiet though. She talks often. So, but you can hear hers too. And she's definitely not going to be hunting in the woods. But you can hear them. And so, yes, that could be a factor maybe. If they don't want to hear that continuous clicking, you really can't hear it a lot until you really focus in on it. So, I mean, there's not a whole lot of difference, like I said, until you really focus in. But when it's pitch quiet, I mean, you can hear a pin drop in it. You can hear it. You definitely can. Okay. So let's think about that. When we're doing our physical assessment, you're definitely going to be able to hear that synthetic valve. You're going to hear that distinct kind of metallic click to it. Okay. Patient education for valvular disease, valvular replacement. This is also box 29.10, page 713. So we've already talked about a lot of these, but let's just kind of review. Disease education wise, if they've already developed heart failure, I need to talk to them about the signs and symptoms of heart failure, taking their diuretics appropriately as they should. When do I need to go to the doctor or to the emergency room when I have developed those significant symptoms? Drug therapy, anticoagulants, we gotta talk to them about that anticoagulant therapy. Do they need to be on it? When do they need to take it? How often? We're gonna talk about some more education in just a minute, so hold on just a second. Dieting wise, dieting can play a factor in that Coumadin therapy. But their salt intake as well. They need to do some diet modifications. Maybe they're a little bit overweight, so they need to lose a little bit of weight so not to put so much strain on that heart. So we can talk about those diet options. If they're compliant with their drug therapy. Antibiotic therapy. Why did I put that? That's kind of important. It really is. Why antibiotic therapy? Am I taking antibiotics all the time? No. When am I taking them?
When you have endocarditis.
It's the next bullet point, guys. It says dental procedures.
Oh.
I didn't realize I put it on there apparently. So dental procedures. Really any type of infection, but extremely dental procedures. If I have some type of sore in my mouth or an infected tooth, or I'm having just generalized dental cleaning procedures, there's a high chance that any type of bacteria that I can have, the first place that it's gonna travel to is my heart. Once that infection gets into my heart, where is it going to attach to?
The lungs.
The valves.
Sorry.
The valves, yeah. So the valves, either the prosthetic or the synthetic valve or that pig or cow valve, it's going to attach there and then it's gonna lay up. And that's where we're gonna get the vegetation that Josh was talking about earlier. And so I need to be on some prophylactic type of antibiotic therapy. Either the dentist may prescribe it to you, or your primary care provider may have it prescribed to you, or you may talk to like a cardiothoracic surgeon that did your procedure. And they may just go ahead and order you some to have on file PRN as needed for dental work or dental cleanings. So then you just go to the, it just clicked. So. And so you may just go to the pharmacy whenever you're fixing to have a cleaning and say, hey, I need to get my PRN antibiotic. Take it a couple days before, just to kind of be prophylactic at it, kill whatever might be happening, or even decrease the amount of bacteria that's in your mouth. And then you might take it for a day or two after, and then you go on about your day. Okay. So you're gonna talk to your primary care provider, probably your cardiothoracic surgeon, and you're gonna talk to your dentist all at the same time and let them know all on board, hey, I've had a valve repair, this is what I need, and then what do you think about it? And the dentist's gonna be like, okay, have you taken your antibiotics today before they do that dental work? Okay. So these are gonna affect our activities of daily living as well. If they have that right-sided hypertrophy, or if they have some left ventricular dysfunction, that's gonna change my tolerance level for. I'm trying to die. Oh my goodness. Let's take a break, guys. 5 minutes.